Good evening, everybody. Assalamu alaikum. On behalf of the Emirates Orthopaedic Society and the AOTrauma, we are presenting this evening our seminar on case discussion. I welcome our regulars from the Dubai Club on this webinar. We are missing you for sure, and hopefully we will have a great discussion today on different aspects of trauma. So we have Dr. Ali, Dr. Saeed, and Dr. Hayder from the Emirates chapter, AO chapter, and each one will have some cases to discuss. I think we will start with Dr. Ali Belooshi first on his case, and I hope the rest will join us soon. Thank you.
Assalamu alaikum. Good evening, everybody. It's great to see you all. طبعا great thanks to Dr. Salim Al-Shahri. He's the leading surgeon who's always been organizing this, and we stopped this Ortho Club regular meeting for now almost 3 months. The last one was in Feb. So we started this one as a webinar, and then hopefully the next one, I'm really hopeful next one going to be a meeting together in a nice hotel and enjoying beautiful dinner. So we brought some nice cases. So the first case that we're going to talk about, I'll start with my case and then we'll follow with Saeed's case. This is how the Ortho Club usually is. We have a group of regulars who enjoy coming on a Wednesday, last Wednesday of every month, where we share knowledge and also socialize and get to know how is everyone. And it's really fantastic because we really enjoy it. And then afterward, there is a beautiful dinner. So this time it's a dry night, but you are welcome to eat as you are watching our cases from your own kitchen this time. So the first case I wanted to share, since this is like AO kind of social activity, we're focusing mainly on fracture cases. So this is a typical case of a 81-year-old lady who fell down at home and sustained a femur shaft fracture. It's an isolated injury, no head injury, and no MI, no CVA. So she had a previous fracture on the same side almost 3 years ago, which was operated on. And after that, she was managing well at home, independent walker, and living with family. Her past medical history, typical diabetic, hypertension, and she is early dementia. She's still quite with it, but still, I mean, sometimes she comes off and on, so it makes an issue, which always we face those. Known case of osteoporosis on treatment. On examination, no other injury. It's an isolated injury with a short, externally rotated lower extremity and skin intact, neurovascularly intact. So this is her X-ray. So what we see, and she had a previous hemiarthroplasty, and she fractured just at the tip of the prosthesis. So if we could see, I mean, this fracture, both of them are AP because you cannot get the lateral because you cannot rotate it. So we just have one view, which is an AP. And the femur prosthesis is cemented and appears to be well fixed in place. And the fracture just right at the tip, quite transverse fracture without comminution. And then distally, there is no fracture. We could see she's severely osteoporotic. It's paper thin femur. So the decision here, we have to proceed with surgery. So the first thing we have to think about here, how to stabilize this patient and when it's safe to operate. So once the patient's conditions being optimized, ready for surgery, we go ahead and take the patient for surgery. The concepts of these fractures, what do you want? You want to have indirect reduction, if you can do that. And if it's difficult, you could make a small incision and reduce that fragment. And then use an EMIPO technique to slide your plate and then get relative stability. We definitely don't need absolute stability. And then we want to achieve length, alignment, rotation. So one thing here is very important to check is this from classification. What you guys classified? If you use the most common classification, which is a Vancouver classification, so this is a C because it's just at the end of the prosthesis. And the implant is well fixed, so we don't need to worry about it. What we need to achieve here is just fix the fracture. So we want direct or indirect reduction according to how we want, but we want to achieve acceptable alignment, length, rotation. And through a position here, it's a transverse fracture. So I opted to open this fracture to really reduce it nicely and then make small incision and slide the plate. So here is the principle in osteoporotic fracture. You have to use a very long plate because you need to span the whole femur. And this is a very important concept. You need to span the femur to prevent future fracture, as she fractured at the tip here. So if you put another kind of going for 6-hole plate with screws, maybe 6-hole distal, 6-hole proximal, 6-hole proximal, then you will end up with a fracture distal to that. So the idea here, you have to use a very long plate to span the whole femur. And then because she's osteoporotic, we have to use a locking plate. And across the stem here, we cannot put screw to get bicortical. So you could use cable. But then we have to remember there are new advances that happen. We have a locking attachment plate, which is really fantastic tool because it allows me to place screws across the cortex to get bicortical fixation. And I love to use a combination of cable and this locking attachment plate because there are studies showing that it is stronger when you have a transverse fracture with a small gap. It is a much stiffer construct and gives you a much stable fixation. So this was my plan, and this is what we did for this lady. So the longest plate available, this was the longest plate available. I would have loved to use the longer, especially distally, to come really where we usually put these plates. But when I did that, it was very short proximally, and I needed to have a good length proximally. I wanted to have at least 4 cortex fixation with the locking attachment plate and then 2 cables. So it ended up this way. So I was happy. I mean, not extremely happy because I wanted to a bit longer, but this is the longest we have. And you can see there is a small gap here, but because we have cable and we have this locking attachment plate, it is a stiffer construct and it should tolerate the mobility. So my post-op rehab for this one going to be weight bearing as tolerated right away because she is demented, very difficult to follow. And luckily she is very thin and small lady. So we allowed her to put weight bearing as tolerated right away. So this is the locking attachment plate. If you haven't seen it, what you do, you lock the locking attachment plate into the plate with the locking screw. And then it allows you to fire bicortical screws in different direction and really helps you to get a much better construct, especially in axial load compared to cable alone. And then there are these unicortical kind of prosthetic locking screws. The advantage of these, you basically don't go into the metal, this way preventing corrosion. At the same time, you are not avoiding contact with the stem and also with the weak area of the bone causing crack of the stem, of the femoral shaft around the prosthesis. It's really lovely tool. This is another lovely tool where you basically lock this nut passer for the cable and you lock it in place and then you pass the cable through it. This way prevent the sliding of the cable around the plate. So this is a study looking into locking attachment plate and compared to cable alone. It shows that if you use locking attachment plate with bicortical screw fixation, your construct is stiffer, especially in axial load in Vancouver B proximal femoral fracture and a cemented total hip replacement. So how about using just locking attachment plate alone or just screws alone or cable alone? So what is better? So what shows if you use a combination of cable with screws is better than screws alone, and then definitely better than cable alone in axial load. but in bending and torsion was equivalent, no difference. How about immediate weight bearing? This study confirms that if you use a standardized approach with less invasive locking plate, immediate unrestricted weight bearing appears to be safe and feasible in this very vulnerable group of patients who are osteoporotic. At the same time, they might have other problems such as dementia. Very difficult to follow your orders, so you want these patients to apply weight bearing right away. So take home message, whenever you have periprosthetic fracture, you want relative stability. You want to span the whole osteoporotic bone. Use your locking plate and use locking plate attachment. And at the area where you have a prosthesis, use a cable combination with screws, because this will give you a better fixation, especially in axial load short transverse fracture. Thank you very much. Now I'd like to take any questions from the participants.
Ali, the first question, and isn't cement mental defected by the fracture distally?
No. We can see this is basically well cemented, the prosthesis, that is proximally completely stable. And that small fracture is very distal to it. And you can see the cement at the very distal here. So it was very stable proximally. So the prosthesis proximally, your prosthesis cement mental composite is solid, and prosthesis is not loose.
Okay.
So the question is why this fracture happened. I mean, I would have think this probably would happen if you have a varus placement of the stem, but from this position, it looks well centered. So I think it's just very osteoporotic. She fell down, and then the transition of very soft bone into a stiff prosthesis cement combo, leading the area to be weak and a stress riser.
Eliado Sanchez from Spain, he said the construct seemed to be quite stiff with two screws close to the fracture. If you show the bow stop, the two screws just distal to the tip.
Yeah. Here, these ones?
Yeah.
Yeah, we'll apply the near far. Distal to the stem, I just place two here. I apply this one first, and then I compress the fracture. I put these first, and then I put another one here to compress the gap, to decrease the gap. So this is what I did. I applied these first, and then I apply this locking attachment plate proximally to kind of the farthest away point, and then I put a cable very proximal. Distally, I use the spanning method, so basically spanning the whole area here.
I think Ali agree with Eliado. The two screws, maybe you could have done one, the most distal one, to allow the fracture to move, and instead of having two, it will become too stiff closer to the fracture side.
Yeah, the reason, Saeed, what I did first, we slide this plate here. I put my K wire here, and then K wire here, and then what I did, I just got my fixation distal. I placed the screw here. Sorry, just keep jumping. I placed the screw here, and then I tried to. I placed this lateral attachment plate here first, distally. I put my screws here, and then I wanted to use this screw to close the gap because there was a gap. But even with that, it didn't happen. This is why I said, okay, it's in the medial side, I have a gap, but laterally it was really nicely closed. So I thought maybe it's just there is, I'm not going to compress more. So then I removed that screw, and I didn't want to leave a hole here empty. So I placed this locking screw.
Okay.
But I agree with you. I mean, it would have been less stiff for sure.
The other question is about bone graft. And there's one question about using a bone graft. The second one,
What do you mean?
there is any need for bone graft?
Yeah, I mean, here, if if you see the cortex appeared to be all right. If I was having a problem placing the cable and then really compressing with the 80 Newton torque, if I noticed that, then I would have used a strut allograft, but it didn't happen. It was really getting to that 80 Newton and without breaking the cortex, far cortex. So I was happy, just there is no need to use a strut. In this case, I don't think there is a need for a strut, but in cases when you have very severe osteoporotic bone and you're compressing the cable, if you break the cortex with that force, then you might need to add a strut medially. But for this case, no, there was no need.
Another question is, why not using custom-made long stem?
She's an 81-year-old lady, demented, and you would convert this operation to a very difficult, complex hip revision. You will lose bone proximally, trying to remove this prosthesis and then removing all the cement mental to put your longer prosthesis in. It will really make this operation difficult. You will lose more bone, and then this patient is very fragile. It might put her into a second hit trauma with a lengthy surgery requiring the transfusion. I think it's an overkill. Plus, distally, you will not have any purchase because it's very osteoporotic. You will need to do either impaction grafting, or you could do, if you do long cementing, then you risk the fracture and non-union. So I think it just makes the operation much more difficult. It's much easier to fix a fracture than do a reconstruction in this case. Given the fact that the prosthesis was stable, it's a blessing. So no need to challenge it.
Final question about using anti-osteoporotic drugs, or is this related to bisphosphonate treatment?
She is getting actually the Forteo injections. So it wasn't related to bisphosphonates.
Before the surgery?
Before the surgery, yeah, she's on Forteo. She had this operation 3 years ago, Saeed, for a hip fracture.
Yes.
Femur fracture. And then she fell down 3 years after the index surgery, while being on Forteo and calcium vitamin D.
Okay. Final question about controlling rotational alignment, but with your extension that will control the rotation and as well as the screws.
Yeah, I mean, here we looking at the femur and then checking rotation. Plus, I made an incision there. I reduced it nicely. So it's through direct vision at the same time as alignment rotation by checking your hip rotation and knee as well.
Good. Okay, so I think we should go to the next. So there's nothing to declare. This is a 26 years old gentleman who was involved in a car accident. He had right tibia, gastello 3B open fracture. He had intramedullary nail with muscle free flap soleus, and he was present to my clinic 18 months following his initial surgery. The question will be, what is next? Or we can hear. We can put the first question, Ahmed, if you don't mind, for Bull. This is his skin from at the site of the free flap. So if you don't mind joining us in this answering the question, please. How would you manage this case? Can you please vote? So majority here voting for exchange nail and bone graft versus 1/3 is talking about Elizarov or external Proximal. So the thing is, when we need to understand this case, we need to look at what approach we will need to utilize. We have a non-union and we need to address that. And as well as we have a broken, all the locking screws are broken. So you can see all these are broken proximally and distally, and I don't know why the circulage was used at the first. I have no idea, but maybe there's a reason they felt it's needed at that time. It depends on the open fracture status. So we need to go with this bone graft. You need to talk to the plastic surgeon who did the flap, which we did, and we talked, and we thought that we can do, as majority of you, an exchange iron nail with the bone graft. So we talked to the plastic surgeon. He said, you can cut from here. This is a soleus flap, has a medial attachment with a free pedicle on the medial side. No need to go from here, we can go here. So we did, and we went and we did exchange nail, and we were happy with this at that time. We use a lot of bone graft, but 4 months later, still we didn't see much union. So we thought we need to dynamize this fracture and to see maybe this is will finally help. Of course, when we did this case, we cut the fibula to allow it to compress, to tibia to be compressed. But again, we did a dynamization. It didn't help. And we removed the full proximal screw, and still nothing. Actually, the fibula healed in a crooked way, and we were having some issue with the patient with his insurance to fully cover and his financial status to do this. So anyway, we end up having a shorter tibia, externally rotated into valgus, and we measured the length. It's about 2 centimeter or 3 centimeter plus this area here, which is didn't heal. So the question now, Ahmed, if you can put the third question, what to do next? Okay, so we can do a blade and screws, exchange iron nail, TSF or Zarov, external fixator with vascularized fibula. So we tried to do something. Zarov TSF bone graft is a very good choice. We elect to do something different completely, but it is the same in the same wavelength. We need to do bone transport at the end. We need to excise this non-union area, and this is what we did. We use a precise nail, which is a grown nail, and we cut the bone at the non-union site. I put a blade to compress it. We pass the nail all the way down. We lock it down here. I was worried that if I need to blade it there. Otherwise, it might distract through the non-union. And we put tons of bone graft posterior to the tibia. Of course, we put some screws on the fibular head and the distal fibula to avoid injuring to the proximal or the distal tibiofibular joint. And this is at 9 months. You can see we regenerate the full 5 centimeter difference in his length. The one we excised the bone, and the one was shortened from the previous procedures. And this was from last week when we removed his nails. And I try to avoid going back to that soleus flap, because last time when we went with the blade, It takes him like 2 to 3 months to heal at the corner. So we try to not to violate. So I left at the blade with the screws at the distally, but you can see it is totally healed, and we regenerate the bone. The beauty with this, we don't need to go through external fixator or bends site infection. This is all internally, and even cosmetically is better for the patient, and it will do the same job. And you can see we regenerate, the length is equal 42.39 or 42.44 between the two sides. So the patient was very happy with this. The take-home message from this case: tibia gastro 3B fracture has a high risk for non-union. Careful communication with the plastic or flap surgery to avoid devitalization of the graft. Bone transport with an air or external fixator is indicated for such non-union. Thank you.
Okay, Saeed, this is a really fantastic case. So I think it's a great solution having this smart nail. The only concern is the cost, right?
Yes, it is very costly, but it is covered by the insurance here in Dubai.
I see. Good. So they don't give you a lot of headache to get approval for these cases.
And if it's, you see, most of the cases here, they will send for second opinion, and if the second opinion support the concept, the insurance. I've done so far 5 cases, Ali, as you know, and they are all covered by insurance.
Great. It's great to know that. The question, Saeed, when you go back to the original X-ray, and he was almost 2 years after that surgery.
Yes.
Initially, and there was basically atrophic non-union, and it's not infected. Did you think that this is related, that you have dead bone there, that should have been excised from the beginning, and then kind of going with this? In hindsight, would you think this way?
Well, of course, we are always wise when we look retrospect. And that's why I put the poll question for the first case, and you can see that 2/3 of the people will do exactly what I did. And most of, we always think, we always think that we are smarter than the one before us. And we think we can do better nail than the one before. But you have to understand it is not us, it's the concept. It is not only the fixation, it's the biology. This patient has type 3B. Maybe I should have done this on the first instant, and we could have avoided all that when wasting another year in his care, because it was a 3B. Yes, he had flap, the bone that didn't heal. Most likely this is sclerotic bone, this is cortical bone. I should have done excise that non-union and I don't have the nail at that time. I could have used the TSF, and I've done several TSF in the past, as you know, and we could have won it.
So there's one question from Eladio Sora. So why do you think when it failed, maybe you should not dynamize?
That maybe that will stimulate it, because when I went to the surgery, I decorticate the edge of the bone, and I use a lot of bone graft there. So I thought maybe this will allow it to heal. Sometime your focus in your case, and you think about the patient, and you try to avoid doing a bigger procedure, but maybe the simplest thing is to do the bigger procedure from the beginning and get over with it.
There's a question, concept of syndesmotic screws above and below. You explained it. This is not syndesmotic, this is through the joints, basically,
Yes.
proximal, just to prevent this articulation of the joints.
Exactly. If you do the distraction, there's, as you know, there's interosseous membrane between the tibia and fibula. And as you push the tibia down, that might bring the fibula down with you, and that will injure the common peroneal nerve, or it will injure the ankle down in the syndesmosis, and that will affect the stability of the distal tibiofibular joint. So it's better to protect it, and you can remove it anytime after you finish your lengthening, only for the time of lengthening.
All right, so last question, role of BMP in this case?
Well, I don't believe
Nothing better than bone transport, I guess.
I don't believe in it.
All right, good. Fantastic, Saeed case. Thank you very much. Now, is Hayder, your presentation ready?
Okay, so thank you very much for the invitation. I have this 25 years old male. He is a motorbike rider, hit a ball. He has a pelvis fracture, left ankle fracture, left foot fracture, left rib fracture, L4, L5 transverse process fracture. His body mass index is 39, as you see, and he has this right femur fracture. Of course, distal femoral nail is the best option in this because it is somewhat distal fracture and he's obese patient. And this is the post-op X-ray for this nail, and there is a primary dynamization done because there is some gap at the fracture site, and this is short oblique. And this 6 weeks post-op, this is just to check the length and the rotation. This is static scan for both lower limb, and this is 12 weeks post-op. Still, there is no clear healing. This is 6 months post-op. At this stage, he did gastric sleeve, and he started to decrease weight. And this is 1 year after surgery. Still, there is no healing. So he presented after that with pain with movement and clear there is non-union. So what's have been done? It's a revision surgery, exchange nailing, exchange rim nailing with larger size nail. And the patient now he lost about 60 kilograms. And this is another 1 year post of the second surgery. Still the patient has no clear union. He has some callus, but there is no union. Pain at the fracture site, and the patient, especially with walking, he has pain, and you can see the size of the thigh is decreased because he lost the weight. Now, so what's the option now? We have, this is the second time. So CT done for the patient, and you can see there is a clear non-union, and we can see there is hypertrophic edges at the site of the fracture. So we need to think about some more stability for that patient. And also, of course, we need some bone graft. We don't know exactly this bariatric surgery, how it's affect the bone graft. There is no study published. Now we have a few cases. They have bariatric surgery, then they developed femur non-union in young patients. We need to think about it. Yes, there is something related to absorption of the calcium, absorption of the vitamin D, but there is no study about it. So what's done after that, it's to have exchange nailing, and this time we give more stability, dynamic and static screws with add a plate on the nail, and we add the bone graft also, taken from the iliac crest. You can see the effect on the iliac crest. And now we give more stability with bone graft, so we attack the biological issue, the mechanical issue, and this is the post-op X-ray. And fortunately, 6 months after surgery, he has full healing, no pain, everything is done. This is his last visit to the clinic. So if we go to the studies, many studies talk about plate augmentation, leaving the nail in situ, and bone grafting for non-union or femoral shaft fracture. And most of these studies proved very good results if you just add a plate over the nail. And plate augmentation with retention from the nail is effective for resistant femoral shaft non-union. I think if patient come from the first time, we can do this. But as you know, if there is non-union, the golden standard is to go for exchange nailing. So generally, in summary, mechanical stability is important for bone healing. The plate over nail option is good choice for femur non-union. Bone graft, you need to add it if it is atrophic non-union. At the end, stability always relieves pain. Thank you very much.
Well done, Hayder. Thank you very much. So this is a kind of an interesting concept where you have a nail and you did an exchange nail and the augmentation was with the plate. So if we go back to the first nail and second nail, we still see a gap across the fracture side.
So yeah, so it is dynamized from the beginning. If you see proximally, we have only the dynamic screw. There is no static screw to allow compression at the fracture site. But I think in this primary dynamization, it's open with two edges because it allows more movement at the fracture site. It's allow not only compression, it's allow some macro movement at the fracture site which prevent healing. So because there is some gap and we couldn't achieve compression at the fracture site, we started directly primary dynamization, putting only the dynamic screw proximally, not the static screw.
But you think, Hayder, because there was a comminution, maybe that was not maybe the best thing to do? Maybe
Exactly. Now, if I return back, better in the first session to have very good stability. Yep. Better to have two screws, okay? Then later on, the patient, if come after 12 weeks with some problem, we can do dynamization. Primary dynamization, we can use it in a transverse mid-shaft fracture only. If like this, there is comminution, there is butterfly segment, and there is oblique fracture, not really transverse fracture, it's not a good option.
Cannot agree more. I think that's a very excellent story from this, conclusion from this case. There is a question actually to you, Hayder. I think you addressed it by basically, I think that was a premature question. They suggested augmented the compression plate and bone grafting.
It's done already. Done, augmented plate with bone grafting. Yeah. This is what's done. So you attack biological and mechanical because this is the third time we do surgery for the patient. We need to give him good solution. But if there is hypertrophic non-union, really there is no need for bone graft. It is a mechanical problem. You solve the mechanical problem just to give more stability by adding plate over the nail. If there is atrophic non-union, we need the bone graft. But in this patient, we know it's hypertrophic non-union more than atrophic non-union. But because of his bariatric surgery, we are afraid from some metallic issue, some problem with absorption. We are collecting these cases and try to find some solution why these patients after bariatric surgery, they have femur non-union.
I think that's a very excellent point because these patients are malnourished. They have malabsorption as well, and they have multiple minerals and vitamin deficiency. So it's really nice to look at them as a reason for non-union. Hayder, is your protocol changing now because of this concept of plating over a nail? That you will go to this rather than exchange nailing?
Still exchange nailing is the gold standard, except in special cases. Exchange nailing is the usual. If we have non-union and long bone, femur or tibia, we go directly for exchange nailing. But in some special cases, we need to add a plate over the nail. Still, it is not our routine. I know. We have Rashid Hospital more fracture fracture than non-union. Non-union is less. We have it. Maybe they are going to other hospital, but still, if there is non-union clear, we go for exchange nailing. And with reaming, we are do bone graft. Reaming is bone graft. Usually, ream nail, larger nail, use it. Except this case, we tried with him exchange nailing, so we shifted to the other option to add a plate over the nail.
Okay, very good. Thanks a lot, Hayder. We still have 10 minutes, 8 minutes. So, Mr. President, you want to share with us your case, maybe?
Thanks for moderating. You guys did a great job. At least we shift gear to an upper limb case. It's not going to be long. It's an interesting case that, so this is a young fella. He's about in his 20s, presenting with elbow pain and stiffness, 3 months post-RAF of his left elbow after a fall, bad fall. And this surgery was actually done somewhere else. So I got the operative note, and it tells me that there was a lateral collateral ligament injury. It was diagnosed as terrible triad, and had a repair of the lateral collateral along with RAF of the radial head and neck. Post-operatively, it seemed to be that the patient was immobilized in a cast for about 6 weeks. which is very unusual. Normally, we try to fix people and get them going, particularly the elbow. The elbow is, as you guys know, is one of the most unforgiving joint. And the whole premise of doing a secure and a good fixation is to get that, especially in a complex injury, to get the elbow going sooner rather than later. Having the elbow immobilized after surgery for 6 weeks, you have doomed that elbow to failure. He might heal, but he'll never probably move. And so therefore, surprisingly, now that's what the patient said, that he was 6 weeks. But when I've seen him 3 months, he seemed to have still some range of motion. He have 45 to 100 degree, supination about 20 degrees, and pronation is locked at 0. There is no pronation, has a little bit of 20 of supination, and again he has significant extension, a lag of about 45 degrees. So now let me go look at the x-ray. So anyway, I've done a blood test just to make sure he doesn't have a high CRP or anything like that. Seemed to be the wound, the scar was very good. It was a lateral incision. It was healed and cleaned. Now those are the elbow films, and what I've noticed, particularly on the, there is non-union at the 3 months, a delayed non-union. We cannot say non-union, it's a delayed union, and some failure, I feel, of the implant. That's what I thought. This is our decision at that time, that there was lock-in, there was some loosening of the screws, and I think this, although we did not see the original films, those are the films at 3 months, seem to be non-healing, and there is some displacement. Looking at that radial head on a lateral view, we felt that that's not gonna move, that's not gonna heal, and there's displacement. So at the time, the decision was made is to revise, and to be honest, not only revise, we would remove those, the osteosynthesis, the plate and screws, and replace it with a radial head. So that's what we've done. We wanted to, he was very unhappy with the stiffness and the residual pain, so we explained to the patient that the only thing we can do is to revise the surgery and replace it with a radial head, so, and do a capsular release so we can get the joint moving faster, and hopefully that's what, so we did that. And next thing, this is what it is after 3 weeks. Now, 3 weeks postoperatively, the patient developed swelling over his left elbow around the incision site. His CRP went up. He did not have a fever. So we looked at it, there was redness over the wound, and we thought it could be a superficial infection. We started on antibiotics. Patient did not get better. 2 days later, he developed an abscess at the proximal end of his wound over the lateral aspect of the elbow. So it was a fluctuant. So we thought, well, we had to take him to the OR. So we did go to the OR, and we opened him up, and that's what it came out. Obviously, it was a deep wound infection, so we had to open it fully, debride it, clean it up, and I thought at that time we had no other options, only to remove the radial head. So that radial head was removed. So with the removal of the radial head, we put him on 2 weeks of, we put him actually on 3 weeks of antibiotics. And we started with range of motion exercises once the wound was healed. And it's almost, we were thinking he's a worker, he's a manual worker. We thought, should we go back to re-implant? And this is something the participant or the panelists can think about it. Should we go to re-implant or not? At the time when we've taken the radial head out, we have checked for stability. And it seemed to be that the medial collateral ligament was stable. Although this supposed to be a terrible triad, actually that's what it was told on papers, but his coronoid was not that bad. It could have been a grade 1 or just a tip of the coronoid, but it wasn't that bad, to be honest. So it was stable enough, and so we got him to go with range of motion, and it's almost a year. Almost, we did this back about 2 years ago, and now, and on a recent conversation, I haven't seen him. He had a very good range of motion according to the patient. He doesn't wish to have any surgery done, and he is, although he's a manual worker, he's managing very well. So he's happy with the outcome eventually. And was there a need to do another replacement? In this particular case, there was no need. Just to get some take home message on this particular case. So radial head trauma could be a part of a complex injury. A low-grade infection could be a cause. You never forget when someone is presenting to you with persistent pain, delayed union following osteosynthesis, you need to always think could be a low-grade infection. When we did the blood work on this guy, now the question was, was he infected all along? Was he infected after the second case, or was he infected prior when we put in the radial head? But it was a low grade, did not show. Maybe we should have taken a biopsy at the time, although his CRB and his blood work at the time of the first surgery or our surgery was normal. But we did not take a biopsy. Maybe this is in retrospective, could have been something we could have done. But often a low-grade biopsy, a low-grade infection, even on a biopsy, it might not show unless it's cultured in a certain way. So high index of suspicion and prompt treatment is important to avoid the sequelae of undiagnosed low-grade septic arthritis. And though even in a young man, and I thought a manual worker like him who want to lift heavy and all that, I thought he might feel a weak elbow and he may need a radial head. As we know, the radial head is a secondary stabilizer. The primary stabilizer for valgus stress would be the MCL in an elbow. But even this patient did not, he was managing very well, and therefore he did not come back to us. So as long as you have a good collateral ligament and a good coronoid, I think those patients will continue to do well. Thank you. That's all for me.
Thanks a lot, Dr. Ali, for being brave and sharing with us a case that you went in to do good and then ended up with infection. And sharing with us how you dealt with it. This is a really nice case. So the question that I have, I mean, it's the same principle that we apply when we do a knee arthroplasty. Whenever there is hardware and we go in and we want to do an arthroplasty, so let's say post-traumatic osteoarthritis, there is high incidence of infection in these cases. So there might be a low-grade infection under the implants or prosthesis, previous hardware that you're removing. So I think this probably applies here, and I think you made a good point of doing a pre-op labs and then maybe sending some frozen section, but then the frozen section depends on the reader as well. you have to have a pathologist who know what he's looking for. I think that's a valid point. The question that I'm getting from the participants is, why didn't you apply DARE principle, which we do in arthroplasty? If you have an acute infection, there isn't biofilm, so why not just retain the prosthesis and just do a washout IV antibiotic after sending all the cultures, and then get the organism and then target it with the antibiotic specific to the organism and retain the prosthesis?
You know, I think in this particular case is you cannot apply the same principle as you would do in a knee and a hip. Those are major joints. When you're looking at a prosthesis like a radial head, what's the, you know, you have to look at the pros and cons of retaining a prosthesis like this. And I felt there are more cons rather than pros for retaining a prosthesis and putting this person on aggressive. I felt in this, when you looked at the video that I showed you, and the pus that came out, is I felt it, we would not win with just debridement and keeping this prosthesis in. That's my gut feeling. Now, if it was a total elbow replacement, that might be a different story. We might have given it a chance to do what you've said, clean it up, put him on antibiotics, and maybe come back and see if it helps or not. But to try to retain the prosthesis in a larger joint, or in a total shoulder replacement or a total knee, you may consider things like that. But in a small prosthesis like a radial head, I feel this guy has gone through 2 procedures and both of them seem to be failing. I wanted to give him one. I wanted to remove this because I felt the elbow was still stable and give him a chance of faster recovery. This patient was not a guy who is a good compliant. He's wasn't a compliant guy. He was difficult to deal with, a smoker. So we wanted to get this healed, and I told him that specifically, let we get this healed, remove everything, get it healed, put him on IV antibiotics. And actually he was on IV antibiotics for 10 days in hospital, and then he left home. We just wanted to get rid of that. And after that, he did well. Now we thought we might have to come back and do another reinsertion, but he did not want, first of all, I did not think he needed it, and he was against any idea of another surgical intervention. So that was my decision in this small prosthesis. That's why I'm saying this is a radial head prosthesis. Now, could it be different for a total elbow, like an elbow prosthesis, a total elbow or a total shoulder? Maybe I would have thought about it differently, but in this particular case, this is the way I managed.
I think you made a good point about.
I don't know if Dr. Saeed has something to say about it, if he would like to share his thoughts about this.
How about the organism? If you, before going in to do the washout and maybe removal of the prosthesis, did you guys make an attempt to take a knee, an elbow
aspirate? Yes, we tried to aspirate, but we were not able to manage. But would that, you know, we treated this like an acute sepsis, Ali. So on high suspicion, you should go after it fast. And to wait for an organism, it takes about 48 hours. I was worried about the joint, the articular cartilage, the damage, chondrolysis from an infection. You know, as you know, when you are suspecting, when you have a high suspicion of an infection or sepsis in the joint, you have to go and try to drain it and clean it up. You can aspirate. I don't know, you aspirate at the time of drainage for sure, like we did send a sample at the time when you saw that pus coming. But already, unfortunately, we already had antibiotics. You know, that's the problem. The patient was already on antibiotics. That will interfere with whatever culture you may get, and you may not get a culture actually. And actually, we did not get a positive culture on that particular case.
I think
this is the one thing we always get, right? Whenever we're dealing with prosthesis inside and patient go to the emergencies and GP, we always come with antibiotic on boards. So one protocol that I follow in these cases, Dr. Ali, is to hold off antibiotics and then give him at least a week, and then go inside and then send cultures. And this way you have a better chance of getting some organism. This way you could target the post-excision arthroplasty or kind of antibiotic placement with the targeted IV antibiotics to the organism.
I think, Ali, you see, the message is, and this is repeated several times, by the time we see the patient, the emergency staff already load the patient with antibiotics. And this is, I think, ruin a lot of our culture, and that will affect our result in how we treat. The point that Dr. Ali made, the radial head replacement, in my opinion, it's an option, not like a full elbow replacement. People, if the intraosseous membrane and there's no sign of any proximal migration, maybe you didn't need even to do replacement of the head. They did already the replacement, and so there will be some scar tissue. So removing the implant, I think it's a wise. That's avoid the second procedure coming, and you can always do it another time once everything is done. And I think it will be a big question if you keep it, and how you justify keeping it, especially it's not as an essential replacement in the elbow.
You have a question, Ali, from Dr. Khalid Abu Abid. If the patient came to you from the first instant, would you use a plate or prosthesis, the first surgery?
Well, Ali, I think normally when I have a comminuted radial head with a neck, I prepare myself. I get a CT scan, 3D reconstruction. It depends as well if you've got other injuries, coronoid, is a terrible triad, if you have a lateral ligament. But anyway, for the radial head alone or radial head with a neck, you need, if it's a simple fracture of the radial head, you know yourself, you're gonna salvage, hopefully you're gonna treat it. But if you have a comminution, it's more than 3 pieces, and some of those fragments sometimes fly underneath the olecranon, and you know, they are in different places. You need to chase them and put them together, and you have a radial neck. Maybe I would always have a prosthesis beside. I always go into the OR having the prosthesis in on one tray, and having the OR on the all the plate and screws on that. So I go and prepare myself for both. Now, if there was significant comminution, I tend to go with a replacement. I would go with a replacement. If I feel, especially I feel sometimes with a radial neck. Studies have shown whenever you put in, when there's a radial neck with a radial head comminution and a radial neck fracture, it seems to be the healing, the outcome is not as good when you have an isolated radial head on its own. But when there is a neck, even comminution in the neck, I think it's better to go, I feel, with the prosthesis myself. But I go anyway prepared, and this is the best thing. You need to go prepared that you're able to do anything and leave it as an intraoperative assessment and decide on it at the time of surgery. But always go prepared. Just like sometimes we do when we have significant proximal humerus head fracture and a split head or something, that you go in preparing yourself for prosthesis, hemiprosthesis, and as well like an OREA.
All right, awesome. Thanks a million, Abu Adam. So at the end, I would like to thank all the participants. I'll let Dr. Salim Al-Shehri do this honor.
Thank you very much, Ali, and hi, everybody. Really, it was very nice webinar meeting. Thank you, Dr. Ali, and for our chairman as well, Dr. Ali Suwaidi, and for Dr. Saeed and Dr. Hayder. Really, it was very nice cases, very good participant, and thanks for all. And thanks for the organizing company as well.
Thanks a million, everyone.
Thanks, everybody. Thanks a lot for joining.
Thank you.
Take care. مع السلامة.
Take care.
مع السلامة.
Thank you. Thank you very much. مع السلامة. Thank you.